Our next speaker is a founder and the medical director of Kaplan Center Integrative Medicine. He is also the author of the book Total Recovery, a revolutionary new approach to breaking the cycle of pain and depression. This book is available to purchase at our reception booth if interested. He is a pioneer and a leader in the field of integrative medicine. He is one of the only 19 physicians in the country who's board certified for both family practice medicine and pain medicine. Our presenter also serves as a clinical associate professor at Georgetown University School of Medicine and teaches graduate students in the Department of Physiology. The title of his talk today, Management of Mold Toxicity in the Patients with Chronic Neuro-Immunologically Mediated Neuroinflammatory Disease. It's a tongue twister, it's a mouthful right there. Please put your hands together for Dr. Gary Kaplan.
Thank you. Stand up. Shake it off. There's nothing like doing a little neuroimmunology at the very end of the day. Like, oh my God. So a couple of jumping jacks, cross yourself, okay? Drink some water. We now know through studies that a little bit of dehydration goes a long way to brain fog and focus and concentration issues. So we want to make sure we're hydrated. All right, we have a huge amount to cover. I apologize, I want to lay out a foundation for you. What I want to do is let you try and understand the mechanisms via which these processes occur, and then once you understand the basis of the neuroimmunology, a map, if you will, of how we get sick and why we stay sick, then we can talk about how we can recover. And it's really important to know this map. So A.T. Still, founder of my end of the profession, I wanted it understood that I look upon the treating of effects as being as unwarranted as it would be for a fireman of a city to fight the smoke and pay no attention to the cause that produces it. I'm speaking to believers here, so this is not an issue. Treatment is actually pretty straightforward in all of these conditions. You just have to find what the problem is, identify that. You need to treat the issue, eliminate it. Be it mold, be it Lyme, be it EBV, whatever the issue is, we need to eliminate it. But then phase 3 is the trick, and this is the one we forget about, because phase 3 is about what happens to the immune system once it's been upregulated too vigorously or too long. And if you fail to do this, you'll fail in getting total resolution with your cases.
100 million Americans suffer from chronic pain. That's 1 out of every 3 suffering from migraines, fibromyalgia, neck and back pain, rheumatoid arthritis. The list goes on. It's more than those who have cancer, diabetes, and heart disease combined. Chronic pain affects our lives drastically. 47.5 million people reported a disability last year. The 2 largest groups were chronic pain patients with arthritis or back and spinal problems. Medical and lost productivity expenses cost Americans over $600 billion each year. There is a huge overlap of chronic pain patients suffering from depression, anxiety, or PTSD, conditions which alone cost an additional $138 billion a year. The success rate for chronic pain and depression treated separately is 47%. Over 50% of patients suffer from both, making successful treatment an abysmal 9%. Narcotic sales are through the roof for chronic pain sufferers, but research shows they just don't work. Narcotics can target the pain, but not the problem. It's time to rethink how we treat chronic pain. It all starts in one place, the brain. New research shows chronic pain and depression are not diseases, but symptoms. These symptoms are the result of an inflammation in the brain brought on by a host of factors, including prior injury or disease, environmental factors, even stress and emotional factors. A brain on fire. We need a completely new approach to research and treatment. Instead of masking the pain, doctors can focus on identifying and treating the sources of the inflammation, increasing the successful treatment for patients. There's still much to learn about how inflammation starts, what makes it better, and how to prevent it. Let's bring together the world's experts to find a cure and bring hope to chronic pain sufferers.
What we've done for years and years and years is we treat symptoms. We don't treat the disease. All right, now those of you sitting in the room have gone far enough that you're actually looking to try and understand what the disease is. Mycotoxicity, Lyme disease, the list is quite long. And so what do we do in terms of what is the underlying disease? And so we started to take a look at this, and by we, as I was fortunate to be able to put together a study group from colleagues at NIH and at Georgetown, and started to look at why there was so much comorbidity between chronic pain and depression. And what did we start to find out? There's a lot of overlap between the neuroanatomy, there's a lot of overlap between the neuroendocrinology, there's a lot of overlap in the neuroimmunology, and there's a lot of overlap in the neurotransmitters that were being impacted. Indeed, if we look at a map of the brain and we look at the nuclei that are involved in chronic pain and depression, there's a huge overlap in terms of the centers of the brain that are impacted. If we look at neurotransmitters, we see that there's inflammatory cytokines altered the metabolism of serotonin and dopamine. We see that there's this regulation of both serotonin and norepinephrine and dysregulation of glutamate, again, in both conditions. If we look at the HPA axis, now the HPA axis, I would argue, shouldn't be the HPA axis. It's actually the hippocampal amygdala HPA axis. Because why is it that we see this axis going south in these people who are struggling with chronic pain and depression? And the answer is neuroinflammation. We'll get to exactly the mechanism of that in a minute, but the hippocampus, the dendritic nuclei in the hippocampus, happens to be the area of highest turnover of cells in the brain, most susceptible to inflammation, and the hippocampal volume, as you just learned, starts to shrink in inflamed brains. The end result of which that balance between the hippocampus and the amygdala gets thrown off, and now the whole HPA axis is dysregulatory. So it's not the HPA axis per se. You got to step back a little bit and look at what's going on in terms of degeneration going on centrally. We know that there's a lot of elevated inflammatory cytokines going on, interleukin-1, interleukin-2, TNF-alpha, and these conditions are neurodegenerative, and we need to keep that in mind. They're not just neuroinflammatory, they're neurodegenerative. So chronic pain and depression, we know, are neuroinflammatory, neurodegenerative, and neurodysregulatory. The brain has a way it needs to chat with itself, and if that gets thrown off, everything gets thrown off. So what's inflammation? Inflammation isn't a bad thing. We need it to heal. But if we don't understand what the inflammation, what the etiology and the mechanism of the inflammation is, we don't know what we're shooting for. So if you skin your knee and it gets infected and it gets all red and pussy, that's an inflamed knee, right? What do you treat it with? You treat it with an antibiotic. If you've got allergies, the mucosa of the nasal passages is swollen, you're reacting to allergens in the air, what do you treat it with? Well, symptomatically, you might treat it with an antihistamine, good anti-inflammatory in this particular case, but that sure is not going to work in terms of the knee, so you don't want to use the same thing. What about headaches? Headaches, we know, are a sterile inflammatory disease, but the story gets a bit more complex. So in one sense, the anatomy, the neuroimmunity in the brain is relatively straightforward. There's basically three cells we need to be concerned with: the microglia, the astrocytes, and the mast cells. So let's take a look at what it is that sets these things off, okay? So microglia comprise about 6.5% of all the glial cells in the brain. Remember, once upon a time, we were taught, those of us old enough in medical school, that the whole purpose of the glial was to provide a kind of a cytoskeleton for the brain, and it didn't have any other function. It turns out that actually it's fully functioning other half of the brain, and if the glial system's not working, you're screwed. So one of the things that happens is the microglia, which are responsible, they're the innate immune system in the central nervous system. Makes it easy for us. That's probably it. So what happens with microglia, if we go take a look at them, they're the resident innate immune system in the central nervous system. They're the electricians of the CNS. That they do early on when we were first born, we've got this massive amount of neuronal development going on, all these pathways being developed, and they get crossed and they get mixed up. And the job of the microglia is to go in there and make sure those pathways stay straight and true. And then what happens is, as time goes on, the microglia move into a sessile state. They move into a state of observing and seeing whether or not there's any damage going on in the system. The microglia are also the only piece of the central nervous system not officially attached to anything else. They have amoeboid function. They can move through the system. Okay? So microgliosis is this process that microglia go into when they get stimulated. They can increase in cell numbers, morphologic changes that can move them all the way into a macrophage stage. There's phenotypic changes in terms of protein expressions that change with each. Basically, when microglia get activated, there's cell damage. They move into a phenotype where they start excreting all kinds of inflammatory factors. The first job as a microglia is to walk into the damaged building, and in order to clear the area for renovation, they've got to open up the space. They take down the old walls, they take down everything that's been broken, and then they start to secrete a series of factors, brain-derived neurotrophic factor, to bring in reparative factors. All right, so, and then they're supposed to go back down and stop putting out anything. So they're extremely important in repair. And so then the question becomes, all right, what is it that sets off microglia? And the answer, in short, are DAMPs and PAMPs. So what are DAMPs and PAMPs? So DAMPs and PAMPs. So PAMPs are pathogen-associated molecular patterns. They're present in organisms other than us. And when they occur in our system, Lyme disease, Epstein-Barr, other infections, meningococcal infections, whatnot, all of these things get taken in. The microglia have senses on them, toll-like receptors 2 and 1, that can pick up these molecular patterns, and then they move into a process to destroy these things. That's their job. Okay? And if there's enough invasion, they'll move fully into the macrophage stage and engulf them and eat them up. Examples of the etiology of PAMPs, all the infectious agents, right? Streptococcal, tuberculosis, dengue fever, okay? And I have patients who've had dengue, and I've had patients who've had malaria who are still sick because of the assault that occurred on their neuroimmune systems. So you need to go thinking about, this is part of your differential. Are any of these factors in play? The examples of PAMPs are the pieces of the bacteria and the viruses that come in, so double-stranded DNA, the flagellin endotoxins, and lipopolysaccharides. So that's DAMPs, that's PAMPs. What about DAMPs? DAMPs are basically everything that belongs inside the cell now coming out of the cell because there's been damage to the neurons. Right? So as soon as that stuff starts to extrude, and that can be initiated through any of a number of processes, which include toxins, trauma, ischemia, cancer. And so then what happens is you have cell death. They start extruding these factors, and these factors are the things that come out of the cell. Okay? Non-proteins include ATPs, uric acid, heparin sulfate, and then RNA, DNA. And then that activates the microglia, and off they go to the races. So now what are DAMPs? Well, concussions, certainly, obviously. Emotional stress. We know that bullying will actually set off microglia. We know that long-term stress sets off microglia. There's neuronal damage that occurs with this. Environmental toxins, which we're going to be focused on today, hypoxia, heavy metals, mold toxins. And so now that we know that the problem is a neuroinflammatory condition, we can now turn around and say, okay, our differential is DAMPs and PAMPs. So DAMPs and PAMPs come off, microglia move into their inflammatory state, and neurotoxic factors start getting excreted. Reaction oxygen species, TNF-alpha, interleukin-1 beta. And again, this is just the diagram illustrating all the DAMPs and PAMPs that can affect this stuff. But what comes out the other end? What comes out the other end, phenotypically, behaviorally, is depression, anxiety disorders, fatigue, malaise, focus and concentration problems, sleep disturbances, POTS, autonomic nervous system disorders. Okay, so what we're looking at clinically are the symptoms of an inflamed brain, a neuroinflammatory process. We now know that. Back up, what is it that set off the inflammatory process? Microglia also possess memory. There's an article that just came out in Nature, published the other day, that talked about microglial memory. And it says, you know what? Maybe that's the priming that's occurred in this long-term inflammatory process for amyotrophic lateral sclerosis, multiple sclerosis, Parkinson's disease, Alzheimer's. The innate immune system has memory. We need to keep that in mind because If we don't keep that in mind, we forget that we have to go back and shut that down after we've eliminated all the toxins. Otherwise, the problem continues. Astrocytes. We don't know as much about astrocytes. They're a bit trickier. We know they're there for structural support. They're there for nutritional support of neurons. They modulate synaptic transmission. And they play a role certainly in spinal and central sensitization. There's also this thing called glial scars. Glial scars are when there's been an ischemic damage or some assault to the brain and the astrocytes come in and pave that over. Some of those glial scars are highly reactive and lead to a hypersensitization syndrome, allodynia. Some of them are essentially dead zones. We still have much to learn about glial scars. But astrocytes play into the role in terms of feeding back and forth where you have. At any rate, so basically you see the microglia has been upregulated as a result of damage, but the other thing that happens is then they kick off the astrocytes. There's a positive feedback loop that goes where the astrocytes kick off a number of oxygen species and nitric species, the end result of which is more neuronal damage, with more activation of microglia, and direct activation by the astrocytes in terms of modulating the microglia as well. We don't know enough about specific what we can do to shut down the astrocyte process, but it's in the mix and we have to figure it out. Mast cells. People have alluded on several cases today about mast cells. They're white cells. You all know what they are, that play a role in the peripheral nervous system, but they also may be the first responder in the central nervous system as well, because mast cells are capable of crossing the blood-brain barrier in healthy individuals. All the other immune systems can't cross the blood-brain barrier unless you're sick and inflamed. As long as you get a healthy blood-brain barrier, mast cells wander in and out. And there's some suggestion that mast cells actually may be the initiators of the microglia. They're virtually on the surface of every single organ interfacing. All right, so mast cells release a whole series of immunomodulators, chemoattractants, vasoactive compounds, neuropeptides, growth factors, in response to allergens, pathogens, emotional stress, tissue damage, and they constitute another part of the innate immune system. There's a whole condition that we've now recognized called mast cell activation disorder. All right, and it turns out probably to be the biggest issue with mast cells. These are non-cancerous conditions. So it's a condition featuring chronic, inappropriate, non-neoplastic mast cell activation. Results in significant signs and symptoms affecting a wide range, in fact, virtually every single organ system. And if we take a look at what mast cell activation syndrome is capable of doing, you see damage in the systemic system with fatigue, generalized malaise and weight loss, within the respiratory system, the things you would normally expect in terms of congestion and asthma, neurologic, anxiety, depression, decreased concentration, musculoskeletal aches, pains, osteoporosis. Digestive system with abdominal cramps and diarrhea, esophageal reflux, the skin that you expect to see in terms of cutaneous flushing, hives. Cardiovascular, you're going to see hypotension, syncope, near syncope. Sound like POTS? So how much of this is coming to play in a lot of these other conditions? This is a dysregulation of our innate immune system. Specifically, the things that have been specifically documented to be associated with mast cell activation disorder is vulvodynia, postoperative pain syndromes, neuropathic pains, fibromyalgia, bladder spasm syndrome. But look at the self-injurious behavior. These psychological problems that we see happening when the mast cells become dysregulated and start kicking out all of their factors. About 200 factors mast cells push out. So what if we're thinking about this all wrong? In the spinal cord, and this was my aha moment, I was doing a great deal of reading by Wolf, who's the master of peripheral neuropathy, and came to the sudden realization. So I'm dealing with, I have colleagues from NIH who are in psychiatry, and I'm over here in looking at peripheral neuropathies, and we're talking about central sensitization, and it suddenly occurred to me we were not talking about the same thing. Similar, but not the same thing. They were beginning to recognize a neuroinflammatory condition going on, but it was much higher up. Everything we were talking about, my field, chronic pain, we were talking about was limited to the spinal cord level. So we were looking at what's called a central sensitization phenomena mediated via microglia. There's a bunch of other stuff that goes on, but we call that central sensitization. we were seeing people with chronic pain, peripheral neuropathies, and neuropsychiatric conditions. And so we posed that what we should be calling this is central sensitization syndrome. This is a much bigger concept than simply looking at the spinal cord. This condition is neuroinflammatory, it's neurodysregulatory, and it is neurodegenerative. It's bad when this goes on for a very long time in people. Depression and chronic pain share common neurophysiologic, neurobiologic processes. They result in a mutually reinforcing pathological phenomena. All right, depression and chronic pain we used to think caused inflammation, dysregulation, and degeneration of the brain. No. What we now know is that inflammation, dysregulation, and degeneration of brain actually cause chronic pain and depression. So these are the symptoms of a brain on fire, an inflamed brain. So this is a map that I came up with a couple of years ago, looking at the interactions between mast cells, microglia, and astrocytes in terms of its impact on the central nervous system. It was incomplete. So what about the gut-brain axis? There's a huge amount of communication that goes back and forth between the gut and the brain. All right? So we know there's nervous system components via the vagus nerve. We know that there's a huge amount of information between cytokines and neurotransmitters going back and forth. The number one producer of serotonin in the body is the gut. And so there's immunohormonal factors that travel back and forth as the brain and the gut regulate themselves. The brain and the gut, truly the gut is the second brain. And the evidence has only gotten stronger for that. It protects us, the gut microbiome, that about 2.5 pounds of bacteria and viruses and DNA from parasites that constitute the microbiome, protect us against infections. It modulates our immune processes. It regulates our metabolism, responsible for digestion of food. It makes vitamins, and it modulates CNS function. Unhealthy gut, unhealthy brain. Unhealthy brain, unhealthy gut. The gut microbiome determines our intestinal permeability. It determines the functioning of our mucosal immune system. Intestinal motility and sensitivity are governed by the gut microbiome, and release of gastrointestinal hormones and neurotransmitters from the too late in the evening, and endochromatin cells is all regulated by the gut microbiome. This is a great big lecture and stands all by itself. What I'm trying to do is just pull this in so that we're starting to think a little more globally about this problem. It controls the maturation and development of the enteric nervous system and the central nervous system. This is the gut microbiome. Resilience influences our ability to respond to stress. There's a lot of interesting studies in germ-free mice and their resilience ability. The gut microbiome axis memory via regulation of BDNF, cognitive functioning, and the blood-brain barrier. One big thing I want you to remember, two things I want you to remember so far, is chronic pain, depression are symptoms of inflammation in the central nervous system. If you have a leaky gut, you have a leaky brain. If you have a leaky brain, you have a leaky gut. It's not opinion, that's well documented in the literature at this point. So we've got this biaxial communication going back and forth that has to remain intact in order for you to have a healthy brain. Okay, we crossed over lectures. I see what happened. Okay, so I've cut this down, so we've got a little bit of overlap from some of the other stuff, but basically what we know with disruption of the gut microbiome, we see anxiety and depressive disorders. We see autism spectrum disorders. We see Parkinson's disease, multiple sclerosis, Alzheimer's, chronic fatigue syndrome. We see chronic prostatitis, chronic pelvic pain, visceral pain, migraines, fibromyalgia, and arthritis. We have a study that we'll be publishing later this year where we looked at our patients with central sensitization, chronic pain syndromes, and chronic depressive disorder, and we have yet another subtype of presentation with the gut microbiome. Now, we at one time thought that if we could get a fingerprint, that this would be a good biomarker. It's not a good biomarker. What it does is it tells that there's always disruption in the gut microbiome when you're sick. If you fix that, It'll stay fixed for short periods of time, but then revert. You have to do something else. So you've got to be looking at the gut in order to fix it, but you also have to understand that the gut won't fix if the brain isn't fixed. And the brain won't fix if the gut isn't fixed. So you've got to be paying attention to both of these at the same time. So now the picture looks more like this. It's mast cells, microglia, and astrocytes. It's the gut and the hormonal system, the endocrine system. All right, so now what's all this got to do with mycotoxins? Because if that's the map, if that's what the neuroimmunology stuff looks like, then I have a chance to turn around and say, okay, you tell me that your toxin is affecting the brain. Prove it. Show me the studies where we're seeing damage, where activation of microglia, we're seeing activation of astrocytes, and we're seeing activation of mast cells, and what's it doing to the gut microbiome. Because if it's doing those things, then I'll say, yeah, this fits in mechanistically with what we're looking at. This makes sense from a neuroimmunologic perspective about what's going on. If it doesn't match, then I'm going, not so sure. So we all know what mycotoxins are. We know where they're coming from. We've certainly been through all of that today. The thing to keep in mind always on this is that while they're classified by the organs and systems that they're neurotoxic, that they're toxic to, they are neurotoxins, so they have direct impact on the brain, and they're immunotoxins. So they suppress, they screw up the functioning of the immune system. This is just a list that we modified from the CDC and added a few others about different forms of transmission, different mycotoxins, and the health impact that's been documented on those. Routes of exposure we know can be gastrointestinal through ingestion of contaminated food, beverages, and water, respiratory, through aerosol, mucosa, and cutaneous. Nothing new here. Okay. If you look at inhalation versus eating versus cutaneous, in one study looking at acute inhalation of T2, okay, one of the trichosines, mycotoxins in both young and mature mice show that inhalation of T2 mycotoxin 10 times more toxic than systemic administration eating it. Okay? It's at least 20 times more toxic than dermal administration. So the respiratory route is pretty damn deadly. If you look at exposures that happen after, and we've seen this has all been demonstrated beautifully by everyone else who's been lecturing today. The tremors that we saw, the lethargy, the stilted gaits, okay, and in some cases out and out prostration. All right, we've seen this over and over and over again. Brain autopsies in children living in areas with high aflatoxin exposure revealed its presence in 81% of the cases studied. At low dose, aflatoxin B1 compromises the integrity of the blood-brain barrier. Studies suggest that the lipophilic nature of aflatoxins allow their storage in brain tissue. I'd like to connect dots. I like to know that it's not just a function of our opinion, but actually we've got studies backing up what we're thinking about. Oxidative metabolism of AFB1 is active even at very low doses of exposure in neutrophils, dendritic cells, lymphocytes, and monocytes. Okay, they screw up the immune system. In murine studies at CNS-derived cells, AFB1 treatment caused microglia to express pro-inflammatory genes. Good, I like to see that. Overexpression of inducible nitric oxide species, messenger RNA, remained high even after 48 hours of past exposure. This is this microglial memory business again. They got hit, but they're still spewing out inflammatory factors, even though you've shut down the problem that created it to begin with. AFB1 exposure triggers overexpression of toll-like receptors 2 with the activation of kappa beta, leading to an increased secretion in TNF alpha in the microglial cells, more inflammatory factors. So what we're seeing here is fine. We now have evidence that the innate immune system is in fact coming into play. That's what we're looking at, and that's what we wanted to see. We're seeing early cell death in addition to oxidative damage. Looking at the astrocytes specifically, we see the treatment of astrocytes with AFB1 induces higher secretion of a series of inflammatory factors. We see simultaneously that AFB1 exposure triggers the overexpression of pro-apoptotic. We're killing off cells faster than we should be killing them off. Okay, so we're connecting the dots. We've got damage to microglia, we've got direct damage to astrocytes, we've got direct upregulation of microglia, creating inflammatory processes. And this is just a diagram illustrating what happens with the aflatoxins as it impacts both astrocytes and microglia. This is a big deal. This says, here's your connection. This is what's going on neurophysiologically. Ochratoxins, we see that they can contribute to protein synthesis inhibition. They cause decreased cellular proliferation, apoptosis, impairment of barrier function, and increased membrane permeability. They're nephrotoxic, genotoxic, immunotoxic, neurotoxic. They do damage. In the brain, we see compromise of the cytoskeletal integrity of astrocytes by ochratoxins. We see gene expression pertaining to brain inflammatory response system. We see decrease in neuroprotective capacity of the glial cells. We see acute depletion in strial dopamine. We see increased oxidative stress triggering high lipid perioxidase and oxidative DNA damage. We see inhibition of oxidative DNA repair activity. There's a lot going on in terms of what these things do. What belongs in each of these slides, and we flipped lectures, this is the rough copy. There is on your copy is about 130 or 40 references that go with this. So all of that's backed up. All right. Trichothecenes, we know have been used, some families have been used in biologic warfare. We can get all kinds of really nasty illness associated with these, emesis, diarrhea. We're going to need to flip back over to my other lecture because there are things missing here that you need to have. We missed in this that I wanted to make sure we got. So when we go looking at this stuff and our thought process, step one is identify what the problems are. Step two is treat the problem. And step three, we need to go after the upregulated mast cells and the microglia. Yeah. This is how we think about these things. All right? So in our patient history, we're looking for autoimmune issues, psychological issues, metabolic issues, ischemic issues, allergies, and testing appropriately. We throw a very wide net. We take a very comprehensive history. Our intake's 2 hours. And then inclusive of that, we're looking for toxin exposure, and today we're focused on mold, but we're also looking obviously at heavy metals, we're looking at pathogens, we're looking for gut dysbiosis, hypoxia, okay? Hypoxia, 5% of the population of this country goes to bed every night and stops breathing. 85% of those people don't know it. It's a simple history. Just ask. What time do you go to bed? Do you sleep through the night? What time do you get up in the morning? Are you refreshed in the morning? Do you take naps? Do you fall asleep during the day at stop signs, talking to people, sitting in theaters, watching TV, listening to lectures? So I'm really, it's just such an easy thing to find and treat, and we find so many of our patients who have previously had undiagnosed sleep apnea. I really push that all the time. All right, and the medications we use may be doing far more damage than the people came in with. All right, 75% of people that we put on nonsteroidal anti-inflammatory agents will develop ulcerations in the small intestine. 75%. Okay? That screws up the gut microbiome, guys. So we want to pay attention to a lot of things. And so while today we're talking about mold, I want to keep in mind that we are throwing a much bigger net than that. This is the testing that we do. We've used Shoemaker's protocol in the past. Frankly, I'm much happier with real-time testing at this point in time. Now, we did all that. Okay, so one of the things that you want to pay attention to in terms of gliotoxins, and this has been mentioned on several occasions here, is that gliotoxins may be coming from us. So if you've got yeast overgrowth in the gut, it may be that the Candida albicans is in fact what's causing the gliotoxins. So here's a patient we had that we in fact cleared everything else from them, but we couldn't get rid of the gliotoxins. We took a look in the gut and look at the amount of yeast. We found the severity of the dysbiosis. We treated that, and that subsequently resolved the gliotoxins. So this is just more stuff, and the fumonisins can also do damage in the brain. You'll see these in apple juice, on apples. What are we doing to our kids? We see both direct neurotoxicity, we see inhibits axonal growth in cultured hippocampal neurons, and it disrupts the myelination in glial cells. All right, oligodendrocytes are responsible, so it's doing damage to the oligodendrocytes. We looked at IQ, we didn't, but they looked at IQ scores in kids who had been exposed to mycotoxins. And what they found was very significant deficits in their IQ scores. And it was dose dependent. The longer that they were exposed, the worse their IQ scores. Depression is increased in people exposed to damp indoor environments. Patients present with other classic neurologic disorders. We see with pain syndromes, movement disorders, delirium, dementia, disorders of balance and coordination. Well documented and well presented by so many other people this morning. Wonderful videos showing the real damage that can be done by these and what happens when you fix it. Mycotoxins and depression. Patients with mold exposure history report moderate to severe levels of cognitive, physical, and emotional symptoms. This brain fog, difficulty, focus, and concentration. How many of your patients complain of brain fog? Big deal. Almost all of mine. So EEG studies show hypoactivation in the prefrontal cortex, executive functioning. Neuropsychiatric testing indicates impairment similar to those seen in mild traumatic brain injury. Studies demonstrate presence of ochratoxins, aflatoxins, M1, FB1 in the urine and serum of children diagnosed with autism compared to healthy controls. All right, these are frequently single studies. They're not slam dunks, but we have to be paying attention to this. And my bet is there's subsets of these kids who have autism that you fix their mold toxicity and they get better. Not all of them, but subsets of these kids. And we need to figure who those groups are. The gut microbiota impacts the permeability of the intestines and thus absorption and bioavailability of mycotoxins. Right? If the gut's disrupted, you're going to be sucking those things in much more. You've been on chronic non-steroidal anti-inflammatory medications, you got ulcerations in your gut, you are much more susceptible to mycotoxicity. They have a direct impact themselves on the intestinal barrier. They have a direct impairment of the mucosal immune system. And the gut microbiota, when healthy, can actually detoxify the mycotoxins. Tissues with the highest rate of turnover are those most susceptible by mycotoxin. So we want to pay attention to that. Epithelial cells in the intestinal tract, very high turnover rates, right? Mycotoxins in hepatic cells. One of the things that we actually didn't talk about today, which is a very interesting couple of studies we looked at here, that there's a synergy between these mycotoxins. When you got one, it does one thing. You got two, it does many other things. And so just by virtue of getting multiple, and I don't know about you, but almost all my patients come back with multiple mycotoxins when I test. You've got this incredible synergy going on that's doing damage far beyond anything we could understand from any of this, a single one of them. And so this is just a series of the studies looking at comparisons of a couple of different mycotoxins and the synergistic effects they have on each other. This is just an illustration from one of those studies. But keep this in mind. Despite the distinct mechanistic pathways of mycotoxins, once combined, these may lead to additive, synergistic, and antagonistic toxic effects after mixed exposure originated from different environmental sources via gastrointestinal tract and inhalation routes. Combined, they're beyond deadly. Where do we find them in the body? Well, we find them in all kinds of secretions. We know this, and there's lots of places we can go look. The most important component of treatment, which we've said over and over and over again, all the other speakers here, get out of the environment. Treatment, again, that's been kind of gone over quite thoroughly by everybody else. the shoemaker, the sequestering agents, the use of glutathione, amphotericin, nasal spray, various antioxidants, probiotics, dietary interventions, saunas, and exercise. All of this you know about. All right, this is just an example of some of the dietary stuff we can use to clean up the diet. So now we've eliminated this. Let's suppose we've gone through this whole process and we've eliminated all of the toxins. We've eliminated all the infections, but the patient's still sick. Or the patient's 80%, where's the other 20% going to come from? We have to go after the upregulated microglia and mast cells. So if you look at medications that will actually downregulate microglia, the answer are low-dose naltrexone. How many people here use low-dose naltrexone? Excellent. Great stuff. I love it. You can even use low-dose naltrexone in opioid-habituated patients. 0.25. May not want to go much higher than that. And the other thing about using low-dose naltrexone in opioid-habituated patients is it may solve the problem with constipation. Okay, and it may solve the problem with tolerance, because actually one of the processes via which tolerance develops in the central nervous system is via the microglia. So as the microglia get downregulated, the tolerance issue with opioids goes down, and you're able to use less to get more. Celebrex, double-edged sword, right? We got a non-steroidal, but it does in fact reduce inflammation in the central nervous system. Indeed, there are studies looking at low-dose naltrexone and Celebrex combined as adjunctive therapy for treatment of bipolar depression. Bipolar depression at this point is pretty much accepted as a neuroinflammatory disease by pretty much everybody in psychiatry at this point. Okay, maybe not. In the literature, it's actually pretty damn solid. But minocycline's an interesting medication. Minocycline downregulates microglial activity in certain conditions. It seems to work best in post-stroke, thus ischemic situations. Haven't seen it be a real big producer outside of that. Amitriptyline, paroxetine, also potential uses. Supplements. We love supplements, right? And that long list of numbers you have there is all the references. This is an opinion. These are the references where they did the studies and saw the impact of these supplements on the microglia. So indeed, utilizing melatonin, glutathione, quercetin, curcumin, ginkgo, resveratrol, omega-3, and vitamin D. Would I do with patients all of this? No. Pick and choose, but these are the dosages that I generally utilize when I'm working with patients. Is this the be-all and end-all? Nah, it's my best guess based on the literature. Mast cell activation syndrome, we also have to shut that process down as well. Okay, not in everybody, but again, if it looks like there's an argument to be made, we want to go after it. So we want to go after it with H1 blockers, H2 blockers, things that will stabilize mast cells, chromium, sodium, and basically this is the model for going after them. We like ketotifen. Ketotifen both is an antihistamine and a mast cell stabilizer. It's not available as a pill in the United States. It is available as an eye drop, but you can have it compounded to 1 to 2 milligrams, no more than that, used at bedtime. And you may need to use very high dosages of this stuff. So, all right, I'm using Zantac, and I'm using 150 twice a day, 300 twice a day, and am I happy about shutting down the hydrogen atoms in the gut? I'm not so pleased about that, but again, you're compromising and thinking about what you're doing. Utilizing the other antihistamines, you may need to use Claritin at 30 or 40 milligrams in these patients. You ramp them up, you layer things, and you move accordingly. Gastrochrome I like to use a lot, and I've used gastrochrome. A lot of my patients who have significant gastrointestinal problems, hyperemesis, chronic abdominal pain, the gastrochrome has really been a big winner. Go up slow, start at 1 vial every couple of days, then maybe go to 2 vials. Eventually you're going to hit somewhere around 2 vials 4 times a day, but go up slowly, see how they tolerate it. PEA. PEA is a lovely supplement. It seems to actually help balance the relationship between the mast cells and the microglia. It takes a while for it to work, so this is a longer term play. It's not going to happen tomorrow. The first dose you want to use, for the first 2 months, you want to use a capsule 3 times a day, and then wean down from that, according to how your patients are responding. Quercetin, luteol, rutin, again, all shown to help stabilize mast cells, very effective in treatment. Again, don't expect the effects to be within the first week. It's going to take a month to 6 weeks to really see the results of this. Meditation is neuro-soothing. Meditation reduces inflammation in the central nervous system. It allows for regeneration of most of the nuclei in the brain. Big study that a colleague of mine at Georgetown did with the military. The military wanted to know if they could improve resilience in their recruits. And so they did MRI studies looking at their SEALs, and they said, what's different about the Special Forces guys that's different from these other people? And one of the things they found was the insular cortex is dramatically larger in these guys. These guys who get kicks out of dropping into the ocean 3 miles out, swimming in with full gear, and then hopping on an island, taking things, and then coming back. So they said, okay, we've got some early studies in meditation showing that meditation improves the volume of the insular cortex. And sure enough, they did this with the military's guys, multiple MRI studies, and were able to demonstrate significant improvement in insular cortex volume. Did that translate into better responses in the field? They stopped funding it, and we don't know. Exercise has already been discussed. Extremely important part of everything we're doing. It's actually anti-inflammatory in the central nervous system. Sleep hygiene is crucial, and where necessary, psychotherapy. A lot of these people have been traumatized. Unfortunately, a lot of them have been traumatized by our colleagues. Hopefully none of us. But they've been told they've been crazy. They've been told that, you know, my PANDAS kids were going to Children's Hospital in DC for years, and all told that it was all in the kid's head and that it was Munchausen's by proxy, and it was just ugly. And then finally, the head of neurology changed over there, Beth Wells, God bless her, and they said, oh yeah, we believe in PANDAS, after years of really doing damage toward a large number of people. So psychotherapy can be an important part of all this. A lot of these people are really hypersensitized, and we heard about that earlier, and there's a need to quiet down their limbic systems. So, real straightforward, right? We now know the neurophysiology, neuroimmunology of this. We can look for all the potential causes, treat them, make them go away. Once we make them go away, we have to shut down the innate immune system in and of itself. Couldn't be easier. If I were telling you I got everybody better who came into my practice, I would be lying to you. There's still more that we have to learn. There's a whole nother chapter we're now exploring in terms of autoimmunity that's going on with these people. That's to come. We're in the process. So I've got another study group going at Georgetown. When all else fails, I run back home and say, help. And so we're looking at this whole process of molecular mimicry, and we're looking at epigenomics and turning on the autoimmune system and trying to understand how we can help these kids better and do a better job on this. I thank you for your attention. I hope this was useful.